Lesson 3 is Integrative Medicine and Supportive Care. And our first presenter is going to be Dr. Kerri Winterstone from Oregon Health and Science University, talking about the importance of exercise with people with cancer. I know this is a topic a lot of people have asked about in the past, and I think this is the first time we're hearing someone speak on it, so this will be very interesting.
Wonderful. Thank you. I'm going to just take a second to get the technology going here.
As you're doing that, I'm going to compliment your decor. It's a very nicely set up room there.
Thank you. It's real. It's not even a background. Okay. Okay. Well, I really appreciate the opportunity to come and to talk to everybody today. And I'm only able to give you in a short amount of time a very high level overview, but happy to answer specific questions, in the panel discussion or by email afterwards. I really want to make sure that we get the right information to everybody. So just to set up the problem that we're trying to solve here, and I know that everybody on this call understands that, throughout the cancer experience, people face a lot of threats to quality of life, like, trouble completing daily tasks, difficulty sleeping, fatigue can be such a difficult and ubiquitous side effect. Potentially due to deconditioning, higher risks of falls or changes in body composition, which can include loss of muscle or weight gain, a struggle to become or stay physically active. And then I want to acknowledge the emotional side of cancer too, just a constant worry about cancer returning. And then also finding meaning or purpose at end of life. So I know you all know this is a short list, and it's a really challenging list for us to be able to think about how do we make sure we address all of these different threats to somebody's quality of life. Um, and, we really do think that we can use movement as medicine for a lot of these challenges that people face, the same sort of adaptations that people experience when they're training for sport can be very helpful adaptations in terms of managing a chronic illness. So there's been, oops, sorry about this. I got a little auto movement on my slides that I'll try to control. Uh, there's been quite a bit of research on using exercise for um, side effect and symptom management to, let me get my, here we go, to slow down aging, to slow disease progression, and potentially even prevent disease recurrence. So, this isn't a new concept. If you think about, just even early philosophers observed that there was a relationship between movement and health. And when people were sedentary, right, their bodies did not perform to their optimal design. And when they're overtrained, the body gets exhausted. So we need something in between here to optimize, just that our health, both in the absence of illness and preventing illness, and when we are ill. So, how do we move this forward then in terms of, sorry, I'm having a hard time with my slides, right? This is really where our natural state is. And we all know that we've sort of engineered ourselves out of this natural state um, in the last several decades. So, uh, we really want to be able to get everybody back to this natural state where we can optimize our ability to um, do well in the face of a chronic illness. So we're really moving from, just thinking about exercise or physical activity broadly to how can we really prescribe movement like medicine? So just like I think there was just a discussion around clinical trials on before me, the same way that we're trying to develop and determine optimal dosing of drugs, we can do the same thing with exercise. So we want to learn, how much of that drug or exercise is needed to produce a benefit, how much exercise you need to do, how hard, how long, and then are different types of exercise better than others depending on what the outcome is. Right. So we're really moving from thinking about, exercise as kind of this all purpose, like a baby aspirin, to how can we use it like a targeted therapy. So there's been a lot of research in the last decade or so, kind of moving from this kind of general all purpose behavior to a more intentional exercise prescription. So before we get to the prescription side, again, just like drugs, the first step in drug development is determining toxicity and safety of a drug. So there was a lot of concern, and I think it still persists today, about whether or not exercise is safe for people to do during and even after cancer treatment. And in 2010, the first set of guidelines around exercise for people with cancer was developed by the American College of Sports Medicine and a panel of experts. And their job at that point was to be able to review the evidence to determine whether or not exercise was safe for people to do during treatment, or whether or not there were certain kind of precautions that had to be taken. Because at the time, really exercise was not recommended very broadly as a part of clinical care, out of a fear that it might make people too tired to tolerate their treatment. So people were generally advised to rest, right? But what that first set of guidelines concluded is that, people who are living with and beyond cancer should be as physically active as their abilities allow, at the very minimum, to avoid inactivity, that some activity is better than none, and that the health risks of being sedentary, right, outweigh the potential injury risks of being active. Um, People were recommended to continue normal activities as much as possible during and after non-surgical treatments. And again, the overall message was that the benefit outweighed the risk. What this set of guidelines was not able to do, however, is to recommend like a specific exercise prescription to address different cancer-related health outcomes. The general recommendation was that the general physical activity recommendation for all people, which is 150 minutes of moderate to vigorous physical activity per week, was reasonably safe for people with cancer. But we all know that that's kind of a difficult benchmark for a lot of people to reach, even when they're not going through an illness or going through treatment. So we were really striving to see, could we do better than this recommendation? Right. So what we have done since then is updated the guidance. And in 2019, we reviewed, the American College of Sports Medicine pulled together another set of experts. Myself and Dr. Kristen Campbell from University of British Columbia kind of led this panel to review well over 1,100 randomized controlled trials that had been published since that first set of guidelines, to be able to come with more prescriptive exercise recommendations, because we knew from trials that these trials were testing lower amounts of exercise than the general physical activity recommendations and finding benefit. And that can be more achievable and easier to prescribe than that kind of larger public health target goal. So what we were able to conclude is that, 30 minutes of moderate intensity aerobic and or resistance exercise, so either one of those modalities alone or in combination, was enough to have a significant impact on 6 different cancer-related health outcomes. And there was strong evidence behind that. That included reducing cancer-related fatigue, improving health-related quality of life, improving physical functioning, reducing anxiety and depressive symptoms, and not exacerbating lymphedema, which is a common post-surgical risk factor for many cancers. There was also moderate evidence for a benefit of exercise on bone health and on sleep, but not enough to issue a specific prescription. So sort of stay tuned for those. And when you think about the kind of translation of these different benefits to quality of life, right? This means better symptom management during treatment, which could lead to better treatment tolerance, can reduce distress that is heightened during cancer, help people return to work or participate in the activities that are meaningful to them, reduces disability and the loss of independence, and importantly for payers, could reduce healthcare costs. So this is the kind of summary of the recommendation of those guidelines. So in addition to that prescription, just to put some bookends on it, again, starting with the fact that, at the very minimum, avoiding being sedentary can help people start to feel better and kind of move toward that goal. Um, Long term, we still want people to strive toward those public health guidelines of 150 minutes of moderate to vigorous physical activity per week and twice weekly resistance exercise. But really, in order to get, you know, a, a good benefit for many different health outcomes, we found this minimum effective dose of about 90 minutes a week of moderate intensity physical activity, so much more achievable. And really, I want to make sure to emphasize that we do, even though we issue these prescriptions, at the bottom of the line, any exercise is good exercise. So we really want to encourage people to find the activity that they feel that they can do. Um, and usually once you get started in one activity and you're successful, you're willing and interested in exploring kind of a broader exercise program for broader benefits. But in terms of choosing modalities, aerobic exercise has evidence for symptom management, cardiometabolic health, weight control, and mobility. Resistance exercise also good for symptom management. It's a little bit more targeted for musculoskeletal health, but also helps in weight control and mobility. And then even flexibility exercise, which tends to drop out a lot of these guidelines. They used to be in our public health guidelines many years ago. um, I think is important for mobility, particularly if you're a new exerciser, or if you're older. It can improve mood and lead to better sleep. So this is kind of in the yoga category. And I think also has great benefits in terms of being a good starter exercise for people who haven't been active, in a long time. So I want to kind of finish the second half of my talk just addressing the motivation that happens with exercise. Um, it is a behavior and it is challenging for people to engage in regular exercise, particularly when they're going through treatment. So, I want to emphasize that it's important that people can start anywhere, anytime, along the cancer experience. So at the time of diagnosis, beginning an exercise program can help reduce surgical arrests and improve recovery and kind of buffer the deconditioning that can happen with surgery. Uh, and then it also starts to set that habit for reengaging in exercise after recovery. During treatment, chemo, radiation, immunotherapy, uh, exercise can help reduce side effects that can improve treatment tolerance, lead to faster recovery, and help preserve functioning during treatment. And again, setting this habit. Post surgery, chemotherapy, radiation, or even in ongoing therapy, exercise can help alleviate side effects, restore functioning, return to kind of quote unquote normal living or the new normal, and also set the habit. And then really we want to think about exercise as a lifelong complementary therapy that people engage in to optimize their functioning, independence, their emotional well-being. It reduces the risk of other illnesses and recurrence, and again, keep that habit. So if you see the theme throughout here, it's we want to start moving toward exercise as a lifetime component of wellness. I do want to acknowledge like some of the exercise realities. It can be hard. A lot of patients aren't ready to participate in a mainstream fitness program that's out there, or may lack motivation. I'm showing you pictures on the right of three women who were in one of our exercise trials, and women who'd gone through chemotherapy for any cancer, and they all qualified to be in our study. But only the woman on the top was able to actually do the program that we were prescribing. And the women on the bottom, we had to, modify the program considerably because of where they came into the program. So, we know that people have different limitations when they start a program. And so it may be most appropriate to start with physical therapy to address underlying impairments or issues that are keeping you from exercising safely or pain-free, right? And then if you haven't been exercising or you've got some limited mobility, I think the key is really to start by avoiding sedentary behavior. You can use different gentler exercise modes like swimming, stretching, or yoga, tai chi. that also can provide a lot of benefits and maybe much more tolerable, or think about personal training if you have the access and the means for that. And then finding motivation. This can often be the hard part, especially when people are really fatigued. So working on kind of self-efficacy, the belief that you can exercise and you have the ability to, that can be helped by goal setting, both short and long-term goals. And I want to emphasize social support. So engaging your social support network, um, partners, friends, peers, coach, instead of people bringing you food during treatment, ask them to come and go walk with you, right? But that really helps keep the accountability and the enjoyment high. And in terms of just moving toward, what types of programs to engage in, immediate goal is to really avoid inactivity. So just thinking about replacing those sedentary behaviors with more active ones, standing rather than sitting, using the stairs, right? Walking for transportation, um, you know, going into the office and walking to visit your coworkers instead of sending an email, parking farther away, playing on the playground rather than watching. All the simple tips just to start making, kind of normalizing moving in your day to day. And then a lot of other tips here, right? That just engaging in regular occupate, like household activities, can be another way. A lot of times when an activity has purpose, right, people can accomplish something else and be active. It's easier for them to feel like they can do it, right? The goal right now, I would really push for aiming for 4,000 to 7,000 steps per day. That is the new, it used to be 10,000 steps a day, and there's been some really interesting research that has come out that 7,000 steps is really the optimal movement for at least reducing a lot of health risks, and even some benefit comes at 4,000. So think about that as a first goal if you're new to exercise or aren't quite ready for formal exercise yet. I would recommend starting where you are. So like I mentioned, even stretching or yoga is a really good place to start. We did a study at OHSU where we sent women who had just finished cancer treatment. They all women got a recommendation from their provider that they should stay active, and half the women got a DVD with, this is like the public television exercise where you've got three different abilities and you kind of choose your own adventure. You follow the trainer that suits you. And we found that, people followed that DVD, I think, because they had a lot of flexibility, and it reduced their fatigue over time and got them more ready to engage in more formal exercise. As you move toward more structured exercise, like aerobic exercise, again, if you're new, I would recommend, the best, safest advice is to start low and go slow. So this was one of the earliest studies in exercise oncology of symptom limited exercise in women going through chemotherapy or radiation therapy for breast cancer. And this was a home-based walking program. So even a minimum of 15 minutes helped reduce fatigue. And as people worked up to 30 minutes, that helped reduce their fatigue even more, right? So it doesn't take much to start to get a benefit. I am a strong proponent of resistance exercise. It's particularly important as people go through treatment and as they get older, to improve your independence and your kind of daily functioning. So think about incorporating exercise that help your daily functioning. These ones on the right that I'm showing you can be done practically anywhere. The person on the right is actually, I don't really, you could just do a push up against a wall. You can sit up and down from a chair, and doing a core exercise like a plank can strengthen all upper, lower, and core muscle groups. Right? And there you can also get you can get good metabolic benefits from resistance training as well. So if you're, focused on weight control, resistance training is still a good modality. If you've got some mobility limitations, like you're feeling like you've slowed down or you're a little bit weaker, or you need some help with daily activities, I would highly recommend that you start here and then start working on your walking routine, because we want to be able to keep you functioning, right? And then we can get you moving. There is a link on the bottom for a program through the CDC that is a really excellent starting resistance training exercise program. So I recommend you to go there. And if, David, if you need to interrupt me because I'm hitting time, please let me know. I'm almost done. And then in terms of, where you want to strive toward, we do want people to try and move toward the current public health recommendations of enough, 150 minutes of moderate to vigorous aerobic activity and twice weekly strength training. This is what a program could look like, right? So a brisk 30-minute walk, on most days of the week, and then on 2 days engaging in a 30-minute strengthening session. So this is something to reach for as a target. And you can start, just remember, like our kind of current recommendations for people with cancer are, either 30-minute sessions, or you could do a combination of resistance training and exercise, right? So every other day exercise routine. I know in the EHE population, there's some concern around bone metastases. So I don't want that to keep people from exercising. There's a lot of activity right now in the research community trying to really make sure that we can use the evidence to drive recommendations for exercise in people who have metastatic disease to bone. But right now, the belief is that exercise benefits outweigh the risk of a bone fracture, right? You do want to think about some precautions around fall prevention. So that means environmental modification, right? Keeping the house clutter free, good lighting, etc. And balance exercises, because if you don't fall, oftentimes that is the biggest way to avoid fractures. And then there are some exercise contraindications or things to really kind of avoid if you've got bone mets and particularly extensive disease, like impact exercise, any twisting motion or trunk rotation, particularly if it's rapid, no hyperextension or flexion of the spine, and avoiding high velocity motion. So that's when it puts the bone at risk, particularly when it's weak. And then avoiding stressing body areas if they've got multiple bone lesions. So you may opt for low to no impact. And then as the volume of metastatic disease increases, it's recommended to try and seek out a more supervised program if possible. I do want to make a plug for thinking about the caregiver. We do a lot of work in couples coping with cancer, so that we're very interested in using exercise to help patient outcomes, but also caregiver outcomes, because they experience so much stress. I've been a caregiver myself, most recently for my brother with esophageal cancer. And so I know that caregiver strain is very real. And caregivers often forego their own health needs, and they do have, poorer health than people who aren't caring for an ill loved one, because they, avoid their own checkups and going to the doctor, as well as potentially not taking care of their sleep and their physical activity. So they need exercise too. And I really recommend, if couples can exercise together, it improves retention and adherence, and actually becomes enjoyable, helps you keep working together well as a team. And I'm going to finish with some resources. So I have a link up here to the exercise medicine moving through cancer website at the American College of Sports Medicine. So there is a plethora of resources there for patients, providers, and health professionals. Dr. Katie Schmitz, who was the past president of ACSM and a leader in the field, recently wrote a book called Moving Through Cancer, that I highly recommend. And a good colleague of mine, Anna Schwartz, who was one of the pioneers in exercise oncology, now has an app called Cancer Exercise. If you're seeking in-person programming, there's a program called Live Strong at the YMCA that's been going on for over a decade now. And then I run a nonprofit called Fit Together, and we offer online live remote group exercise classes, and I'm happy to talk to you about that. And there's many other organizations like mine that you can find in the Moving Through Cancer website up top. Okay, and I just thank you for your time, and happy to answer questions when we get to the panel.
Thank you much.
Okay.
And we are going to shift to our final speaker for the day before the Ask the Expert panel, Dr. Vesel, who is, if you've followed us in previous years, is a thankfully repeat participant who is always appreciated.
Good afternoon. I do have technical difficulties to put my slides, so I will ask the EHE coordinator to put my slides on. Thank you so much. It's an honor and a pleasure to be here today. Um, I have a very soft spot for patients and clinicians and researchers for EHE over years, and I'm glad to be on this platform again. Um, I'm a palliative care physician taking care of patients with serious illness of all ages, pediatric and adult as well in Boston area. Please move my slide. What I'm hoping to talk today about is trying to think a little bit about the pain today on this session and significance of pain in human experience and cancer experience. And then we'll talk about how to strengthen our body and mind during the chronic care or chronic experience with cancer. I do want to just pause for 1 second and thank Dr. Stone for her incredible talk, because in fact, we are prescribing in palliative care and supportive care exercise all the time. And our patients really appreciate the support of moving. So thank you. Let's go back to the experience of cancer pain. I was hoping to think a little bit with you all about what is pain, what's the history and meaning of pain in humanity or human experience, what happened in 21st century, and the treatment approaches. Next, please. So, next slide, please. What is pain? The definition of pain, I reached back to the International Association of Study of Pain, which is a large organization of researchers, clinicians, and advocates for pain around the world. And the latest or newest definition came about 5-6 years ago, which defines pain as unpleasant sensory and emotional experience associated or resembling that associated with actual and potential tissue damage. Next, please. But what they added too is very important, that those 6 keynotes to what pain actually is, they added pain is always a personal experience. So it's a experience of that particular person, and it's influenced by different degrees of biological, psychological, and social factors. In addition, pain and nociceptions are different phenomena. So when we try to be very descriptive about where the damage is in the body, we may miss the point of patient experience and not design the best treatment. The next is through the life. We actually learn about pain and how we respond to the pain. So the concept of pain is very individual and related to who we are from birth to the end of life. Next point they made is the person's report of an experience as pain should be fully respected. And we get into trouble with that very often. And I'm sure that some of you have this similar experience. Next point they made was, although pain usually serves an adaptive role, it may have adverse effects on function and social and psychological well-being. And the last that they try to point out in this definition is that verbal description is only one of several behaviors to express pain. Inability to communicate does not negate a possibility that human or non-humans experience pain. So it broadens our ability to look at people who could be in pain but are unable to express it, or even our animals that are living next to us. Next, please. Now, when it's actually very interesting to go back to a history of pain, because phylogenetically, the pain is actually supposed to protect us, right? When we learn very early in childhood that when we touch something hot, it may burn us, and a toddler like my 18-month-old grandson already will say hot, 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 because once he touched the heating system. So pain is supposed to protect us, but then something happens over time. That pain is becoming not a signal of protection, but of risk or danger. And that's what happened with cancer. So let's go back to our understanding in the history. In ancient and prehistoric contexts, evidence of pain relief dates back to 5,000 years. So our humanity was trying to look into how to address and alleviate pain. We go back to Mesopotamia, where clay tablets recorded use of opium poppies. Those beautiful red flowers were used actually for pain experience. In Egyptian, we see the use of opium as well. And early civilization, then there were multiple evidence that we were contributing pain as a supernatural cause, evil spirit, demons, or moral transgression, rather than the physical injury. Next, please. When we move forward to the classical and medieval ideas, we look at Greek philosophers who introduce more naturalistic ideas about the pain. Homer described opium use for sorrow. So he started to expand pain beyond the physical, while Aristotle saw pain and pleasure as passion of the soul caused by external circumstances. Hippocrates linked pain as an imbalance of four humors, and in Middle Age, pain was often viewed as a divine punishment. So that's where some of the punishment idea of spirituality or religion came as an idea. Next, please. And then 17th to 19th centuries bringing some scientific advancement. There are ideas about analgesia and anesthesia. In 1965, gate theory came, which is one of the leading theory of by Dr. Melzack and Wall, to integrate psychological factors into the brain processing. And then neurometrics theory that created a biological, psychological, and social model of pain. In 19th century, anesthesia made a huge change in surgical interventions. Ether, chloroform, changed how we operate and the childbirth experience. And then, but at the same time, we still, even at the end of 19th and 20th century, including 21st century, still have a poor understanding and approach to a chronic pain. Next, please. So what's happening in 21st century? There is a significant advancement in clinical and in-lab research around pharmacology of pain until opioid crisis happened, where a use or inappropriate use of opioids, not necessarily in medical settings, but sometimes in medical settings, actually kind of moved us a little bit in the darker ages, I believe. There is now ongoing research looking at non-opioid medications. I will talk about it briefly soon. And then a huge advancement in psychological and lifestyle approaches to pain, and large societies around the world that are working very hard to bring pain management to all people, not just people in the upper income countries or highest income countries. Next, please. So what are the approaches to pain? Definitely good understanding. The patient who comes to a clinician with pain needs to develop a trust with clinician, and it's a bidirectional relationship. And if there is no bidirectional relationship, that probably is not a good clinician to be part of pain experience or pain treatment, unfortunately. Understanding of pain and its meaning to a person requires self-reflection. What pain means? Is it possible that pain to you means such a significant threat beyond the reality that we may need to work on that? Or you are so stoic that you don't recognize pain, but that pain can be a sign of disease progression that clinician needs to be aware of. So there are two sides of the extremes. And then we go to medications. With EHE, we have an experience in the community that anti-inflammatory agents may be actually more potent in pain at some level of cancer progression than opioids. So we published a case of using ketorolac for pain that made a much bigger difference for pain management than anything else that we used in this particular patient with EHE. Opioid use, atypical pain medications, use of ketamine, lidocaine, and then we are very fortunate. It's only last couple of years where new receptors of pain are being discovered. Those are receptors in a periphery instead of peripheral plus central pain receptors. One that's already approved in the United States and is used in Europe is called suzetrigine, which blocks sodium V18 receptors, and they are only in periphery, means that this medication is not going to cause addiction and other side effects, undesirable side effects like seeking behavior, as well as, unfortunately, the respiratory depression that opioids may cause. I appreciated a brief reminder that despite that this medication in the United States is now approved by FDA for use only in acute pain up to 14 days, doesn't mean that we cannot prescribe it for chronic pain. And I personally had unusually positive experiences with this medication recently, and we are looking and awaiting trial of suzetrigine in chronic illness, knowing that the researchers are already looking at receptors next to the V18, sodium channel V18, maybe 17 and 19. So more is coming out in the research domain, and that's very exciting to us. We already heard about invasive procedures by interventional radiologists, and some of the invasive pain treatment and nerve blocks and others definitely with EHE should be considered, including epidural pain management. I cannot be more grateful to the talk that was included today about EHE. About exercise. Sleep is extremely important. When I have a patient in pain, my first question is, does pain wake you up? If it does, it's absolutely an urgency to me to make sure that the patient will be able to have less pain and sleep. And then, of course, diet, supplements, and psychological intervention. Next, please. I would like to move ever so briefly. I know we are all running a little bit late, so I will try to really address the main issues about finding support in time of uncertainty. It's extremely important, and that's what we counsel our patients. The first consultation as a supportive clinician or palliative care clinician is, please build your clinical team actively. And clinical team doesn't have to be the team that you are referred to. You may pick and choose, hopefully, and build the team that talk to each other and trust each other, and you trust them. It's very important to find a way to ground yourself. So really pay attention. Am I still in this fight and flight mode? Unfortunately, in our Western society, we fight against cancer, and EHE is a chronic condition for most people. And being in fight mode all the time, that's not what our body is built for. So it almost feels like we need to rethink a little bit about the society and kind of thinking back about, the society wanted to elevate the fight against cancer, but it can actually burden us as patients and as clinicians, because it becomes how we can live with less adrenergic response, with less sympathetic discharge. So being able to ground ourselves and not to fight all the time, but be grounded. Next would be to think about, are we catastrophizers? Are we thinking ahead, too far ahead, and unable to live in the moment? And is it possible that we can decrease our reactivity? And that could be go back to honesty with your clinicians who can ground you. Yes, it is cancer, but perhaps not to think about what can happen, 20 years later is actually a good idea, because we want you to live the best possible life. Understand your new identity. Am I fighting against the reality that I am now, part of my life is hijacked by being able to be treated for this disease? And if I'm fighting against that idea that, yes, there are days when I'm a patient, and there are days when I am the rest of the population and a human being, that I can let go of the disease, could be helpful to me. So that's an idea about thinking, who am I now, since the diagnosis? Important to care for yourself, but I can't emphasize caring for others. So don't stop just receiving care from others, but give it back a little bit. That reciprocal caring actually improves the outcome of patients with cancer. There's not enough time for me to think about existential maturity, but cancer itself, the diagnosis of cancer for you and the caregivers, pushes our existential maturity. It does force us to look into our self-mortality, regardless of whether it's a chronic illness or an acute cancer with shorter prognosis. And being able to express that to yourself or others, processing that existential growth actually can bring some maturity and ability to cope with it, is worthwhile to consider. And then not losing hope, but understanding that hope may change. It goes through the metamorphosis. And I want to finish with the last slide, please. Because we always have hope until the last moment of our life. And this is a story that I will leave us with before lunch. Pandora, the first mortal woman, received from Zeus a box that she was forbidden to open. The box contained all human blessings and all human curses. Temptation overcame restraint, and Pandora opened it. In a moment, all the curses were released into the world, and all the blessings escaped and were lost, except one, hope. Without hope, mortals could not endure. Thank you very much.
Thank you so much as well. What a beautiful ending to the series.